Now I am excited to bring up to the stage my friend, Gabriella Espinosa. Gabriella is a leading educator, coach, and advocate for menopause, women's health, and sexual health. She's a founder of Women's Body Wisdom and podcast host of Pleasure in the Pause. Please join me in welcoming her to the stage. Thank you. Oh, I can't wait for this panel.
Thank you, Thompson. Welcome, everyone. I am so thrilled to be your moderator for today's panel, putting the va back into your Voom, because we are going there. We're talking about the vaginal, sexual, and urinary health issues that impact us in menopause, the things that too many of us are told to suffer with in silence, and too few providers are trained to talk about. But luckily, we've brought you an incredible lineup of experts who are going to talk to us about this. So I'm going to introduce them and bring them onto the stage. Are we ready?
Yeah.
Okay, great.
Yeah. Soon.
Dr. Kelly Casperson is a urologist, sex educator, TEDx speaker, author, and podcast host of You Are Not Broken, and the founder and CEO of the Casperson Clinic. Dr. Jessica Shepard is an OBGYN and menopause expert, the author of Generation M, founder of Sanctum Med and Wellness here in Dallas. She is also a national medical health expert. You'll see her on Good Morning America and the Today Show, and is also the chief medical officer for her. And Dr. Maria Sophocles is an OBGYN, sex counselor, TEDx speaker, pioneer of vulvo-vaginal laser therapy, sex toy designer, author of The Bedroom Gap, and the contributing producer to an upcoming documentary about midlife sexuality called Hot. And it is going to get very steamy in here today, for sure. Whether you're feeling like your libido is nowhere to be found, or you've decided to put it into retirement, which is okay too, or you're feeling like the Sahara Desert down there, you are not alone. These symptoms are real, but there are solutions. So we're going to get into it, and let's begin with the basics. We're going to start by zooming in on the anatomy, okay? So, because when we say down there, we're actually talking about a number of parts and systems, and they all work together, don't they, Dr. Shepard? So can you walk us through a brief anatomy review?
Yes, I love the anatomy review. So yes, I'm Dr. Jessica Shepard. I'm here right in Dallas, like just up the street at Sanctum Med and Wellness. And, you know, I love discussing what the pelvic system looks like externally and internally, because a lot of women who come in to see me, they'll come in and say, there's something going on down there. And so I'll say, where? And they're like, down there. And so we have that stare off. I don't know if you've seen that stare off, that meme where they just stare at each other, waiting. Because it's so important that we know what's going on in all parts of our body. That's body awareness and self-awareness. And so that is including our genitalia. And so I usually like to give the kind of schematic of an apartment building, right? And if we were right now here today in the room of the vagina, this room right here, I would say an easy way to understand how the pelvis is structured is the floor above us is going to be the urinary system or the bladder, right? And then the floor below us might be what we would say is more of the intestines, the rectum, that area. And so that really shows you the proximity of how close they are together and how well they intertwine, and why it's important for us to know the different compartments, but they're all kind of the same area, which is the pelvis. And in that is going to be a lot of muscles and ligaments and organs, obviously. So now that you know the compartmentalization of it, this is why when we go through perimenopause and menopause, it's important to understand that complexity of it, because our estrogen receptors all over your body. And so when the estrogen is not there anymore, this is how our organs respond. And so this is why you might see your vaginal dryness, which is both can be internally and externally. But also when we think of the bladder, is that rain? Wow. If that's a loud rain. When you have the apartment above, which is the bladder, that's why you start to have maybe more frequent UTIs. And then also, even for the rectum, you can start to have a lot of changes in your bowel as well. So that's just a kind of a quick overview of how the pelvis is structured and how they're intertwined. But externally is also understanding the parts of the body as well, which is what you'll see here externally. I always like to go from top to bottom. So if you were to look there at the top of the diagram, you'll see that's where our clitoris is. I have a lot of my patients who bring in their adolescent daughters and or nieces or whatever, and I always encourage them. I have a mirror in my exam room because I want them to see it. And in seeing it, they can find comfort and understanding that this is not an uncomfortable part of their body, but then I can walk them through it so that they don't have to be my 50 and 6-year-olds who would be like down there. They can say exactly where down there is. So if we go from top to bottom, you'll see there at the top is the clitoris, which is our organ, I guess you could say, of sensitivity and sensuality. But externally, what we see is just a little area. But underneath that, I always say that is kind of the top, and under is like the iceberg. It's kind of like extending with a lot of nerves into the vagina, which is why part of pleasure is not just one area, it's the whole area. And then right below that is what we would say is the urethra. That's where your urine exits, okay? And so then below that is where the vaginal opening is. And this is where we usually, well, when the head of a baby is coming out, usually comes out there. That's where the vagina is. And that's important to understand because if you ask people, where does a baby come? Some people really don't know that it comes out of the vaginal opening. And so being able to understand from top to bottom, outside and inside, is your responsibility to know that so you can explore it, so that you know when something is going on where that exact area is. But this is what we should not feel ashamed about. And for many years and centuries, we have been told to be ashamed of that area. And so I hope that you can at least start with this. Everyone is responsible for taking a mirror out tonight and looking at their vaginas. Yes, you can do it together, you can do it separately. But I really, really encourage you to be the best advocate for yourself, which includes your pelvic system and your pelvic organs. Learn what pleasures you, which is what we'll talk about today. Learn where it is, because then you'll know how to tell someone else where you would like to be pleasured. So enjoy these diagrams. Remember the complexity of the in the room of the vagina, floor above, floor below, and then externally. And there's going to be changes, obviously, as you go through transitions through adolescence, through reproductive years, and your menopause years of what it looks like externally. So do not be scared of your vagina and embrace your body for what it is.
Thank you. Thank you. Aren't our bodies amazing? Female bodies are simply amazing. Thank you so much for that. But we know, Dr. Sophocles, that we experience changes to the vaginal and vulval area that don't always feel so amazing. Can you help us define what's really going on here? What is the genitourinary syndrome of menopause, or GSM, and why does it happen? What's shifting hormonally that leads to this change?
Sure. So thank you for having all of us here. It's great to be here. When we lose estrogen, and we lose estrogen for many reasons, right? Menopause being the most common, 100% of those of us with a vagina, vulva, and uterus are going to lose that estrogen as long as our ovaries either stop making the estrogen, or we have surgery to remove the ovaries, or we have chemo, or we have an immune-related issue. So there are many reasons why we stop having the estrogen benefit that we have in our lives. When we lose that estrogen, it makes changes in the vagina, but also in the vulva, and also in our entire genitourinary syndrome. So that's why we had to change the name from vaginal atrophy to GSM, genitourinary syndrome of menopause. I was in the room when they changed the name, and it was a bunch of people who said, "This is more comprehensive, it's better." And everyone nodded. And then everyone said, "How are we going to say that over and over?" So GSM helps us to say it efficiently. What happens is that we see, well, two main things are that we lose the type of collagen that serves us so well. So we all start out with this Neiman Marcus level, beautiful collagen that makes our vaginas elastic. And God knows we need that elasticity to have babies come out, to have penises go in, to have all kinds of things happen. And that's also we have those beautiful ridgy folds and that deep dark pink color from all those blood vessels. But when we lose estrogen, that good collagen is replaced. So Neiman Marcus goes to IKEA and we get IKEA level collagen that quite simply doesn't really work as well. I mean, we all know IKEA furniture looks great the day you get it for your kid's bedroom. And then a year later, you're like, what is this part? And it's the same thing. So you can even see in the diagram, we go from beautiful, ridgy, dark color to thin, inelastic, pale, even yellowish white tissue that doesn't serve us. And how does this translate to you? This hurts. This is why you come into our offices and you say things like, I hate my vagina, or my vagina feels like there's a cactus in there, or it's dry as the Sahara, or there's shards of glass. We've all heard these. So when the collagen breaks down and is replaced, we get a loss of the rugae and the expandability. When the blood vessels leave town, this is even a bigger tragedy. And that's because we need the blood vessels for urinary health, and Dr. Casperson will tell us about that. But we need the blood vessels. So I'm a gynecologist and a sex therapist, so I talk sex all day. So we need the blood vessels for lubrication. And that lubrication, by the way, isn't just for sex. We need it to ride our bikes and to be comfortable and to just be healthy. But yes, we need it for sex. And when you lose the blood vessels, it doesn't matter how turned on you are in your head, you're not going to get wet. The blood vessels are part of the source for the moisture. So we're going to learn about how we can replace that moisture and how we can replace health and how we can fix GSM, because it's eminently fixable. It's easily fixable. And we've already learned from Dr. Haber and others how inexpensive it is to fix this. So I just think GSM is something that you can still call it vaginal atrophy. I don't really care, but know that it's chronic and it's progressive. And this is another important distinction. Your hot flashes may stop. Your mood changes may improve. You may not want to kill your husband every other day, but you will, if you have GSM, and 50 to 80% of us are going to have it, you will have it for the rest of your life if you don't take care of it. So I tell my patients to think of treating GSM like you do seat belts and sunblock. Nobody wakes up and says, I'm 72. I don't think I need a seatbelt anymore. Or I'm 64. I'm pretty sure I won't get sun damage if I go in the sun now. We don't say that. And you shouldn't say that about your vaginal health either. You should say, I need to keep this health, or if I'm losing it, I need to fix it, and then I need to keep it there. So that's the short and quick of GSM.
Yeah, and it's not just about vaginal dryness, right? So
No.
Dr. Casperson, can you speak to the urinary health implications and also the longer term health and healthcare cost implications of untreated GSM, especially as it relates to chronic UTIs and bladder health?
Yes. So I love the floor metaphor. I often say that the bladder and the vagina are condo mates. They share a wall. Because so many people, they don't understand, number one, that the vagina is an important organ for many things. The vagina provides a healthy microbiome that prevents the poop bugs from going up to the bladder, right? And so it's like a precious moat to protect the bad guys from invading the castle. And the other important thing about the hormones in the pelvis is that people come in because this is a progressive condition that gets worse. The hot flashes and periods were 8 years ago for these people. And I have to spend a lot of time saying, this is because of low hormones. They don't even know that postmenopause is low hormones. They thought they were over it, going back to Dr. Sharon Malone, right? So a lot of this education is estrogen and testosterone receptors are everywhere in your body. And the pelvis continues to deteriorate because it loved being Neiman Marcus. It functioned very well there. And so the bladder takes a hit. We have estrogen receptors in the muscle that makes the bladder make the urine go out. We have testosterone receptors in the pelvic floor that work with stress incontinence, right? When everybody's like, testosterone's only for libido, it's like people's stress incontinence get better on it. There's 2 published papers on that because testosterone receptors are in the pelvis and are involved with GSM. So recurrent UTI, bladder urgency, leakage, getting up at night to pee. Bladder issues is the #1 reason that women enter nursing homes. Urinary tract infections are the part of GSM that will kill you. There is I tell women they come in, I'm like, if there was something that I could give you that decreased your risk of recurrent urinary tract infections by 50%, would you be interested? 100% say, yes, I'm interested. I'm like, that's vaginal estrogen. There is nothing better. And there was an amazing abstract just published this week at the American Urologic Association. They looked at over 11 million women using American health records. And women with recurrent UTIs who were on vaginal estrogen had a 50% decreased risk of sepsis, 20% decreased risk of hospitalization, and a 73% decreased risk of death from their recurrent UTIs. And that just got released this week. So I agree. I think this is seatbelts and sunscreen and vaginal estrogen. When you turn 50, I think it's mammogram, colonoscopy, vaginal estrogen, because GSM is so undertreated and vaginal estrogen is so safe that this is low-hanging fruit in the pelvis. And, when we think about just going into the sex part of it, gray divorces, kids are out of the house, maybe career's done, you've got your maximum net worth, and the relationship ends. One of the top 2 reasons is lack of intimacy. Untreated GSM is a massive cause of relationships breaking up, and nobody talks about it.
Well, let's talk solutions. At least can we get it back to like Nordstrom's or Zara? Morning, Zara. Let's, Dr. Shepherd, can you explain? There's a lot of confusion about vaginal estrogen. So Dr. Shepherd, can you explain how it works and whether it's safe for everyone, including people with estrogen positive cancer?
Yes, vaginal estrogen, just like Dr. Casperson said, is like that low-lying fruit, and where even people who have hesitation or concern, or if they've had a history of breast cancer, is really to understand where is this entry point of where I can maybe consider it, but also the beauty in what it's providing for your pelvis. And so you have to think of it, I think, in 2 different ways. What am I wanting as an expectation or outcome? What do I want for my life? And what's hindering me from getting there? And sometimes it may just be as simple as, what conversation can I have to get me to that point where I would be maybe a little bit more willing and accepting to vaginal estrogen. So I have a lot of these patients who are like, I just keep hearing about hormones and it makes me a little bit itchy just listening to it. And I'm like, well, that actually could be solved if you took the estrogen. But anyway, nonetheless, where can we start? So I always say, where is a starting place and where you might feel comfortable? And vaginal estrogen really is that ability and that modality for you to have something that's going to help with vaginal dryness, but especially for women who have a history of breast cancer. I think that they have been slighted for so long and just kind of excommunicated from any conversation that has to do with hormones. And so when there was a very pivotal paper that was written, I think it was 2023, I think it was end of 2023, about the use of vaginal estrogen in patients who have had a history of breast cancer, and showing that there was no increase in recurrence of breast cancer or mortality, all-cause mortality. And so then that allows them, even in breast cancer history, to re-enter the arena with what's something that's going to help me as well, and that's vaginal estrogen. So we've already explained, and I'm sure you've heard throughout the entire morning, that there are estrogen receptors all over the body. So just to even bring it back down to what is a hormone really is a chemical messenger. And I think it's, if you think of like a mailman or a car assembly line, it's something that's being done and delivered all the time consistently. And so if you don't have that delivery system, and that would be when we have a decline in estrogen and the estrogen is not there to be delivered to the receptor all over our body, what do you think is going to happen? Well, the organ is not going to be able to respond or do the thing that it has been doing for so very long. And so that is, again, replicated in the vagina, in the vaginal spaces, in the vaginal tissue, in the vaginal wall, in the bladder. is that the estrogen is declining, but the receptors are like, but we still really do want to use you, but you're not available. And so that's why we start to see the change with Dr. Sophocles just said that atrophy or the drying or the tissue changes, and then you have pain as a result or bleeding. And this is why vaginal estrogen is such an important tool that everyone in this room could potentially be a candidate for it. And so if you think more of who are the people who can't have it versus who are the people that can, it's the possibility of what if it works. And this is a very safe entry point into giving yourself maybe one of the best chapters of your life when we think of not only just sexual health, but just comfort in myself and knowing that I'm not having pain. That's really, when I think of self-care, and I know there's a lot of, go get a massage or get your pedicure. Those are very important, so don't drop those either. But what is self-care is taking care of who I am because I want to live the best chapter of my life requires intention and making sure that you're putting yourself first. So vaginal estrogen for a win. Everyone is getting, you get vaginal estrogen, everyone's getting a tube when they walk out. I'm just joking. They're going to be like, you said that on stage and now everyone is asking us for a tube. But that is a beautiful way to think of your vagina and your health.
Can you talk to us about the delivery methods? I think there is a slide that
The
addresses.
delivery methods. Let's
Yeah.
do delivery methods.
No.
It's not this one.
Can you just talk us through
Yeah.
the delivery methods?
So you mean vaginal estrogen?
yes.
Oh, okay. I was like, you want to do all of them? So when we think of vaginal estrogen, is you can have delivery systems. So there are different ways and different management ways in which you can use vaginal estrogen. And so that can be for some people who use it just externally. And then there are some people who use it internally. So remember, we went through the anatomy, and when we're talking externally, we're talking about our labia and our mons, and where the clitoris was, that's where we saw the external part versus internal, which is why I say it's like a tube sock. The tube sock is the internal part of your vagina, and the external part is more of your vulva and your labia. And you can use vaginal estrogen on either parts of those. And so whether you use it several times a week versus every day for a week for a certain amount of time, that's where you really need to be intentional with the conversations that you're having with your doctor on what is the issue, why are you there, and why are you considering vaginal estrogen? And then also, what is the modality and what's going to get you to the expectation of what you're looking for as well as the duration. How long is this going to be used for you? Because everybody is different. And I hope that, from the beginning of this morning till the end, everyone understands that. I heard Dr. Joseph saying, we cannot keep comparing ourselves to the person beside us and what worked for them and think that that has to work for you as well. And so everyone who goes in for hormone replacement therapy really needs to understand whether it's testosterone, progestin, and estrogen. You have to know that you are there as an individual, and what you walk out with is going to be a completely different setup and template than anyone else who walks in behind you or walked in before you. So please take note of that, because as we're starting to see more of hormone replacement therapy modalities, I believe that we all have an individual need and request and want. So really go in there for yourself. So back to the vaginal estrogen. So how that is delivered, it can be through, I don't know, who's seen when we think of like yeast infection, diflucan, when we have the tubes. So the tube can be the delivery and how you insert that into the vagina, depending on how many times you use it a week. And then externally, you can use that as well, applied with your finger, and or if you have a Q-tip, that can be delivered. I always say that it's not a lot that is needed externally. So I always have to tell my patients how much they should be using as well. And I always tell my patients, you have to be willing to explore and be curious. If you don't understand something and you're like, I had a patient, I'll give you a story and why I'm saying this is important, who's like, I'm finished with my tube of vaginal estrogen. I was like, but I just prescribed that last week. Like, I'm not understanding why you're finished with this. And so again, asking those simple questions, she was using it too much and too many times. But again, going back to how should I use it? When should I use it? And asking the question if you feel uncomfortable. Never be ashamed to ask questions on what you're using. Do you want any more answers to
I think
that?
we have that slide there.
Oh,
Thank
now,
you so
so
much.
yeah, because this is local
Yeah.
versus systemic. That's why I was asking, because is anyone using vaginal cream orally? I hope not.
I mean,
Do not use
your
it that
crow's
way.
feet are close to your mouth, but it is not orally.
do not insert
The
it
other thing we
too.
have to mention as far as local hormones, don't forget the androgens. There's currently one product that is FDA approved for dyspareunia, which is pain with sex in postmenopausal. It's called Intrarosa or Prasterone, and that is DHEA. It's worth a mention. And the new GSM guidelines that came out on Monday mention androgens 6 times. We're very excited.
Yeah.
So DHEA is a precursor hormone, or it's a hormone that then converts into both estradiol and testosterone within the cells of the vagina and the vulva. It makes chef kiss vulvas because we need both androgens and estrogens. That's how we function, right? So it's a cool medication. My problem with it is it's still brand name and expensive. And Medicare has its issues with covering things that are for sex. Right. But it also it does decrease urinary tract infections. It's just not FDA approved for that. But it's wonderful. It cannot compete dollar for dollar for a tube of vaginal estrogen cream, which you can also put on the external structures and your crow's feet off label, because it is a cream. So we must mention the DHEA. It is a wonderful product, and I do believe some women will benefit. If they're not seeing the results they want with a cheaper vaginal estrogen product, get a good exam by a competent provider, and then you can consider other options.
Can we go back to
One other
yeah,
thing about the estrogen cream, it comes in a tube, it has this inserter. I definitely think whoever invented that was either a male or had a horrible sense of humor. Nobody who has ever washed a dish or a bottle would ever design something that you have to wash out like that
I
on
know.
a regular
That's
basis.
awful.
So I do think if you just use your finger, you have the best inserter right in your own hand. Raise your hand, Mary Claire. And all you have to do is put it to the little first crease. If you put that, people always ask me, what's the exact dose? 2 grams, 3 grams, 4 grams. I say, look at the line, put it to the line, put it in your vagina. You have enough to think about. You do not have to measure, and you do not have to bottle wash these damn inserters. So throw the inserters out.
We do. One of the obstacles for using vaginal estrogen is bringing that box home. It happened to me, bringing that box home, taking out that leaflet, and then seeing that warning. And I've heard so many stories, and it happened to me too. You just put it back in the drawer and like, maybe not. Dr. Casperson, can you talk to us about the black box warning? What do we need to understand about that warning, and should it be cause for concern?
Yeah, so too long didn't read it needs to come off. Because of the WHI and the fear of hormones, the FDA mandated what we call a boxed warning to go on all hormone products, especially all estrogen. Doesn't matter the dose, didn't matter the route, didn't matter what type of estrogen it was, just blatant slap it on everything. And it's wrong, it's incorrect. We actually have published data. If a woman is lucky enough to get a prescription for low dose hormones for her vagina, 20% will still not use it because of the boxed warning, because it says things like heart disease, blood clot, cancer, and not possible dementia, probable dementia. And if that pisses you off that our government label is incorrect and incorrectly fearing women, get the card out in front of you now, take your phone, scan this QR code, because now is the time to get the FDA to pull this off. I think all estrogen products. And they just pulled off an incorrect warning for testosterone for men. So the time is now to get this off for women.
Yep.
Dr. Sophocles, Dr. Casperson mentioned DHEA. Did you want to add anything else about DHEA?
No, I certainly am no DHEA expert, but we use it all the time because DHEA is a naturally occurring hormone. It peaks in our 20s, it descends after that. It helps convert into other hormones. So the reason it's part of this discussion is because so many women think of estrogen and link it to cancer and come to us saying, what else can I use? And again, the DHEA that's commercially available as prasterone is god-awful expensive, but that doesn't mean it doesn't work. And if your insurance company will cover it and you don't mind a nightly vaginal suppository, then by all means use it. I've used it. It makes an incredible amount of moisture, but it can be expensive.
But why would you use it as opposed to vaginal?
I think you would use it because are afraid of estrogen or because there's a cost. You may have some insurance that won't pay for vaginal estrogen. Again, we can't know every insurance and who's going to cover what, but you may also use it because your girlfriend used it and she told you it really helped her, or you read online, or there's an influencer or TikTok person who mentioned it, and you come to us and ask. So our job is to know, is it safe and what's the data? And so I will say one quick thing, that DHEA, for this talk, we're talking about vaginal, but DHEA comes as topical for skin use and as oral. So when we use it orally, and I don't mean we do, but when people do, they often will use it for depression, or they've heard that it helps menopause cognition related issues, or they've heard that it's going to help their libido or orgasm or arousal. The data is pretty mixed on that. So I don't think any of us are going to stand up here, please correct me guys if I'm wrong, and say there is good evidence-based data that oral DHEA is going to solve all these problems. So be very careful about adding one more supplement to your regimen. Where there is a little bit of data on the oral is in building lean muscle mass and reducing fat, but not necessarily muscle strength. So again, before you add one more bottle onto your counter, be aware that I'm not sure oral DHEA is going to be the life changer that you want it to be.
Okay,
And
thank
that's
you.
all I wanted to add.
I would just
you.
add to that. I
Yep.
think, you know, when we have these wonderful abilities to be in rooms like this and hear from experts is the beauty of the blends. I say this all the time is, and I said it before, it's personalized, and what might help you may not help the person beside you. So all of these beautiful things that you're hearing about today may be just your opportunity to say, you know what, in my life right now, what I'm looking for might need a little bit of this and a little bit of that. And it's going to be different from everyone. But the more that you have to choose from, and knowing the safety profiles, what it helps with, what it may not help with. Yeah, there's a lot of data on DHEA and it may be mixed, but there are some people that really do have benefit from it. So again, that's taking the advocacy and the awareness for yourself to say, I have so much information and I'm going to be curious to figure out what is going to help my specific needs, and then the expectation of what I'm looking for in my life and getting there. So it should be lifelong work. It's never going to be, I'm only using vaginal estrogen. That's the only thing that's going to work for me. It may be an addition of something else, but never give up on yourself and continue to go down that journey of what you want your life to look like.
And then speaking of other things that could work, often in the same conversation, we talk or hear about vaginal moisturizers or lubricants. Dr. Shepherd, can you talk to us about that? Are they the same? Should we use them in conjunction with vaginal estrogen?
Yeah, so vaginal estrogen to me is going to be, when you think of a plant, it's going to be that wonderful fertilizer and that deep rooted part that's going to actually help the organ and the mucosa and the vaginal tissue. And so we've talked a lot about what that looks like later on with decreasing UTIs, with enhancing the ability for you to have pleasurable intercourse and sexual intimacy because it's restoring the tissue. But in addition to that, I always go back to it, the beauty of the blends. There are some people who use vaginal estrogen but really love lube. Great. Then you should be using lube. Or you have people who are hesitant about starting vaginal estrogen, and they may get to that point in a while. But in the meantime, I'm like, well, how can we still impact your sexual intimacy? And that may be through using lube first until they get comfortable with, you know what, maybe I'm going to add now vaginal estrogen to my regimen. And so I always advocate for lube, because the other part of that is there are a lot of people who have maybe had sexual trauma in the past. So maybe it's not even a purely estrogen issue, but now the brain has created the obstacle to why they're not experiencing intimacy the way they want to, or maybe they're not enjoying their partner. So the brain really comes into that. And if you are not using lube, then sometimes even just the entry portion of intercourse can be harmful, because now it's an issue of things that you have in your past or in your mind, or maybe you're just preoccupied. So the thing is really to explore everything that's available. Again, looking at it from a safety issue, what you're looking for, the ability to use more than one modality at a time. And maybe if you're not with a partner and you're using a vibrator, then lube is great as well. So I don't think, I say this often, that when we think of women's health, especially in the sexual health space, society has only given us two choices: either you're a nun or a whore. I'm like, well, that doesn't really give us a lot of gray area? What if I am a little bit of a whore and sometimes I'm not? Like, I just don't understand why you only have two choices. And so I think that we have been given like this indication, well, if you're on that side and you're using lube and I don't know, then maybe you're on that end. I'm like, no, everyone can use lube carefully and safely and judiciously as well.
So moisturizers and serums for the face, and that
Safe.
sunscreen.
Oh, it should be what?
Vaginal moisturizers. I mean, I
Yes.
think we don't want to forget that there's something between lube and estrogen.
Yeah,
Vaginal
and I meant
moisturizer-
to comment that as well.
Yeah,
And
are
you can rely
twice a
on that.
week. They contain hyaluronic acid, and it works well because I tell patients it robs Peter to pay Paul, but that's not a bad thing. It's pulling moisture from behind the walls of the vagina. Remember the earlier picture, and we talked about the accordion and all the blood vessels. If you have those blood vessels, you have more moisture to pull. But vaginal moisturizers, remember, they're not lube. You're not using them in the moment. You're using them Monday and Thursday to provide moisture during the week. Do they work? Yes. Do they correct blood vessels and collagen and take you back to Neiman Marcus? No. But they work, and their cost is their cost. I mean, we spend money on other stuff. So sadly, they're not covered by insurance. You have to buy them. But I think that, you spend money on lots of stuff, and certainly vaginal comfort is something else to treat yourself to. But just remember that neither lubricants nor moisturizers are fixing the cells like vaginal estrogen. They're just Band-Aids, but they're wonderful Band-Aids. And I also think we have to destigmatize lube. Lube is for every age. Lube is for a 20-year-old, a 40-year-old, a 60, an 80-year-old, or like my father-in-law's new girlfriend at 89 who just asked me for lube the other day. That was awkward, really more for me than her, believe it or not.
Thank you so much. And what about testosterone, Dr. Casperson? It's showing up more and more in menopause care. What role does it play in women's sexual wellness?
Yeah, so shift a second. We've been talking about local pelvic hormones. Where we're shifting right now is systemic testosterone, meaning it's a product that's dosed that it goes in your bloodstream to multiple places. So much less data on pelvic testosterone. We're talking systemic testosterone now. Where's our biggest sex organ? The brain. Where's libido in the brain? Is it in one little corner on the left side that's only a centimeter? It's the brain, right? And so nothing will irk me more when people are like, it doesn't help mood, it only helps libido. And I'm like, libido is literally called getting in the mood. So these are, if I had my way and I could rename sex hormones, I would rename them neurosteroid hormones or neurohormones, because these are brain and neurologic hormones. They're just messengers. They're not bad things. So we've been using testosterone, not we, because I was not born. We've been using testosterone in women for about 80 years. We've used it to treat breast cancer. We've used it to treat hot flashes. We use it liberally in people who want to transition to men. We have 50-year safety data, published 50-year safety data at 10 times the dose in our trans population. That is wonderful safety. What other drug are there? Anybody willing to take 10 times the dose for 50 years and see how you do? That's the best safety data of any drug out there. It's fantastic. Why aren't we using it? So testosterone is in our bodies. How do you think we make estrogen? Does the ovary just make estrogen? No, the ovary makes testosterone. Cholesterol pathway, right? Cholesterol, progesterone, testosterone, estrogen has the least amount of carbons of all of them, right? You just keep cleaving a carbon as you go down the pathway. So all bodies make testosterone, just in different amounts. And where testosterone really has gained traction is libido. Some people love that because they're like, great, women's sexual health matters. 90% of men are heterosexual. Who do you think we're helping them out with? Viagra's been out since 1997, right? So it's wonderful that we're actually caring about women's libido. And it's actually put testosterone in a box, because we're like, well, but you're not married, so what would you need testosterone for? I see that with vaginal estrogen too, by the way. What do I need vaginal estrogen for? My husband's passed. And then I look at him and I go, was your vagina just for your husband? And then we stare, and then we do the stare off thing. Your vagina is a microbiome world that protects your bladder and blah, blah, blah. It didn't die, right, when the boyfriend left. So some people think it died. So the other amazing thing, just to focus on testosterone and sexual health, because there's a whole world, remember, hormone receptors are everywhere. Testosterone helps clitoral blood flow. They've done a study. They put people on testosterone. They took an ultrasound that measures blood flow and put it on their clitoris artery, and blood flow goes up. Right. So it's arousal, it's libido, it's orgasm. You take a woman who hadn't been on testosterone, you put her on, they're like, orgasms are just easier. It's like, it doesn't take so long to climb the mountain. Right. So all domains, distress about their sex life goes down when women are on testosterone. It's all domains measured in sexuality except for pain. Testosterone doesn't work as well for pain, but we have other things for pain. But all domains of female sexuality is improved with testosterone. So even the people who are like, it's only for libido, well, and all the other domains of sexuality, right? It's not just libido. Is why do you enjoy sex? Just because of my libido. Like, no, there's orgasm, there's arousal. Like the whole point leading up to the orgasm. Nobody talks about that part. That's the best part in many people's opinions, right? So it's all domains of sexuality. We do not have an FDA approved dose. Companies have gone up to the FDA twice. One was right after the Women's Health Initiative, so that's bad timing. We have excellent safety data, efficacy, and it's going to happen. We have people working on this, I promise. Right now, the data we do have in both the UK and the United States, the amount of women taking a testosterone product is equivalent to the amount of men taking a testosterone product. Wow. Just it's insurance doesn't cover it. It's not FDA approved. We have to mess around with our dosing because we don't have a standard dosing. And women are being pushed to the highest dose because of the lack of access that they do have. So I'm very excited for an FDA approved dose because it will legitimize what we have been doing for 80 years.
Thank you. I know we have a long list of questions already in the queue for testosterone, so we'll be talking more about it a little bit later. But let's move on to the pelvic floor. We haven't talked about that yet. It plays a huge role in both urinary and sexual health. Dr. Sophocles, what can pelvic floor therapy offer for things like painful sex, leaking, or UTIs?
Okay, so I kind of don't want to take extra time because there's so much good testosterone stuff, but I'll do the pelvic floor because it merits some time for sure. So pelvic floor physical therapy, which is done by a pelvic floor physical therapist, is a wonderful adjunct to what we all do when we're trying to help women with their genitourinary sexual issues. These are by and large women who actually, it's a very physical job. It's not just listening. They are going to get a glove on, they are going to get lube on, and they are going to get in there in a good, gentle, respectful way to try to help assess what pelvic floor muscles are too tight. What are overstretched? Where is there laxity? How is your posture? How do your hips and your stance? How does that affect how you function and how you have pelvic pain and why you have sexual pain and why you might have urinary or fecal or gas leakage? All of those things and more are in the wheelhouse of a pelvic floor physical therapist. So we use them regularly. The bad news is you tend to have to go in person and it might be covered or it might cost money, but sometimes there is no gain without some pain. So I think all I want to say is that we use them, that what they do, they'll often do biofeedback, they'll do desensitization, which is a fancy term for using silicone little penises called vaginal trainers or dilators to help you if you have vaginismus, one of those cringy words. Vaginismus, everybody knows. Raise your hand. What's vaginismus? Anybody? Everybody know what it is? A bunch of hands go up. It's basically the involuntary tightening of the pelvic floor muscles when we insert something. It's very common, and they can help us with that. They can also help us with pelvic pain, whether it's from surgical scarring, trauma, bad episiotomy, something like that. I could spend an hour talking with Dr. Casperson about how they can help us with bladder issues and leakage and fecal leakage and all kinds of stuff, but know that they're very important. And if your clinician isn't suggesting that be part of a multidisciplinary approach, you might want to just preemptively ask, advocate for yourself and say, you know, I've had this pain for a while and the vaginal estrogen on my perineum helped me 20%, but I still can't really sit comfortably or have sex. They should be mentioning that. And if they're not, you know, you can find someone who will.
And speaking of gains, there's this term, use it or lose it.
Oh, God.
Is there any truth to that, Dr. Sophocles?
So I have to say, I don't want to be Debbie Downer, but I actually don't like that term, use it or lose it.
Yeah.
Okay. I don't like it because it implies that we as women, we have to stay in some sort of sexy, perfect physical, sexual shape like all our lives. And like you were saying, we have to, you know, nun or whore. We also are expected to stay beautiful, stay thin, stay sharp, stay vibrant. And I think that where's that message coming from? It's coming from men. It's coming from the male gaze that we have to please a partner, not that we don't want to. But I want to remind you all that we don't owe a partner this, that we have a right to define sex on our terms and pleasure on our terms. We have a right to pleasure for sure. That's in my TED Talk, I think, the Bill of Sexual Rights or something. But this may not be pleasure from penile penetration. Penis and vagina sex may not be what gives us the most pleasure. So I think when you say, you know, use it or lose it, I'd say two things to that. One is remember that orgasms happen much more readily, much more quickly, much more easily when we take a penis out of the room. It does. It happens better for lesbians, much more easily in lesbian sex, much more easily with self-love. I'm not crapping on penis and vagina sex. I love it myself, but don't give yourself the pressure that you have to use it or lose it, first of all. Second of all, using it doesn't have to be a penis. I think masturbation or self-love, another one of those cringy terms that so many women were taught not to talk about, is something that can help you to enjoy pleasure with your partner. So I think use it or lose it can refer to the fact that you don't have to use it with a penis. You can use it with red light therapy. You can use it with a vibrator. But also that you give yourself grace. You don't have to use it and you're not going to lose it. Okay. So I guess that's how I feel. I'm very
Okay.
I just wanted to add one more thing about and I love that last part. You're not going to lose it if you don't use it, but it's nice to use it though, I will say, but you're not going to.
Well, sex is bigger than a penis and a vagina.
Absolutely. I think that we've typecast it, but about the pelvic physical therapist, I just wanted to make one quick point on that because it is ever so important that knowledge is power. So knowing more about your pelvis and why certain things happen is very important. And that's why we have a pelvic physical therapist in our practice, because many times I can see that something's going on, but my expertise can be extended with someone who knows so much more than me. And I agree with you. Some of the obstacles sometimes is you have to go in person, but now the beauty of technology is where we see that we have devices such as the LV, and other devices as well, Parafit, where then you can use biofeedback through an app and do that at home. So that's the maintenance portion. And so you have the ability to see the expert, get the knowledge base, and then have the curiosity of how it's maybe obstructing your personal health and your physical health, but then using technology for maintenance and increasing and improving your pelvic health over a certain amount of time, because it's not an overnight project. This is something that for years had a lot of wear and tear and pregnancies, or whether it was activities, and just actually loss of estrogen itself plays a part in how your pelvis starts to decrease as far as its vitality over time. So take that time for yourself to understand your pelvis, do the work that's necessary, and then maintain.
And let's get into the good stuff now. What other ways can we employ to reclaim our pleasure? And I know that you talk a lot about different modalities that we can start. How do we start to do that?
One of the ways that you can do that is inward look, is self look into self-awareness, what you were taught. A lot of what we were taught about sexuality and intimacy is very, very tied around what's the word? I say it all the time. What is it?
Shame,
Shame,
stigma.
stigma. But what's
The
the other one?
patriarchy?
Patriarchy. Thank you. I was like, there is a word that I use
I'm
every
gonna throw
time.
that out. That might be wrong.
I was like, thank you. I knew it was there. So patriarchy, shame, guilt. And so that really is messaged very early on in our lives as women, as young girls, and what that really means for us. So then we get older, and our worth, if you think about it, is really framed around the reproductive years. Whether you have kids or not, it doesn't matter. It's about what society deems a woman worthy as, is usually has to do with what she's bringing to the world in the form of reproduction. And that's why we start to see in the perimenopause and menopausal phases, there's this kind of like kick off the cliff of like, thanks so much for your time. And we have to reclaim that. That's our responsibility, is to reclaim that. So how can we do that? Through community, through discussion, exploring curiosity and being self-aware. But also, if you do have a partner, is taking that time to restore intimacy, not necessarily always in the penile vaginal way. And if it's same sex, not necessarily that way too, but how do we connect? Connection is one of the biggest parts of how we can maintain who we are as we start to age. And you have to be willing to do that. So if you do, like, say, couples meditation or couples breath work or yoga. I remember then on Oprah when Sting was on there, and do you remember that interview? And he was like, we have tantric sex
He
for
said he
8
tantric
hours. I was
sex,
like, well,
yeah.
you know, I was really young when that came in. I was like, so he's just using a penis for 8 hours? That's really odd. But what he really meant was that they were connecting, and it was the connection in beyond just sexuality and how we think about it and how we're taught that really created that atmosphere and that experience for them. So again, rebranding who you are in your own sexuality, also pushing away that shame and that stigma, and telling the patriarchy to F off for all things. But then the other thing is, what do I want my life to look like? Always start with that in mind, so then you can do the work to get there. But starting with self, building connection with your partner, and retraining yourself in how you think of intimacy. It's not always about actual intercourse. It's connection and intimacy with another partner.
Well, thank you. And I hear a lot what you're saying alludes to curiosity and novelty. Dr. Casperson, you talk a lot about the use of sex tools, sex toys as a way of introducing that into a relationship or into solo exploration or self-cultivation, as you call it. Can you tell us what are the benefits of sex tools to sexual health, and how might someone begin to incorporate them alone or with a partner if they've never used one before?
Yeah, great questions. So I did an Instagram reel like last week, and I'm like, you guys, I'm going to show you my newest vibrator. And I pull it into the screen, and it's my new electric flosser for my mouth. And I'm like, I have 3 vibrators for my mouth now. And the reason is, and I'm tying it in, is we use technology everywhere. You know, how many people are watching this right now who aren't in the room? Like, technology is amazing, right? So, and frankly, to clean my teeth, the electricity and the electric vibration does better than my hand in a, piece of wood from the tree. That's where we started. So technology is good. It makes no sense that we embrace technology and we shame it in this one area. Like, that's an incredible tech bias that, like, oh yeah, but not for sex. It's like, that's actually ridiculous. So normalize the use of tech, because these people have nailed the exact vibration that the pelvic nerves need to best send a signal to the brain. Like, this is science at this point, right? And lots of other things are fun, but like they're really figuring it out. In the vibrator world, it's not just what your girlfriend's using. Like, there's a lot of different types, looks, styles, external only. They're not all phallic based anymore. There's a lot of external clitoral stimulators, vulvar stimulators, lots of exciting stuff going on to be like, I'm not actually cool with something big and hard going into my vagina. I might have atrophy. I might have not gotten on vaginal estrogen yet, right? So there's a lot of intimidation, and for people to realize there are really more female focused vibrators at this point that have nothing to do with penetration. So we know, who here has heard of the orgasm gap? Oh, we got to talk about that. Yeah. I know Dr. Sophocles. So if you put a heterosexual couple and you quiz all the heterosexual couples, the male will have an orgasm about 95% of the time. He's partnered with the person who has the least amount of orgasms. That's the heterosexual female. She has an orgasm about 65% of the time, and that's in a loving partnered relationship. That's as good as it gets. Hookup sex in college, don't get me started, it's about 7%. I don't recommend hookup college for the heterosexual female. So vibrate, we want to have fun at the party, right? And if you're not having orgasm, we can have a long debate of if that's the end all be all, but orgasm is a marker of pleasure. The more you have fun at the party, the more you actually want to go to the party. I can't make you like mushy broccoli and raw chicken. Like, it's not a great meal, right? So vibrators really do help in pleasure, arousal. And I agree with you 1,000,000%. I hate the use it or lose it. And what do you do when you have a sore back? What do you do when you have a sore shoulder? You rub it. Why? Because it brings in blood flow. What do vibrators do? They bring in blood flow. We know our blood flow goes down because our hormones have gone down. And just with aging, let alone comorbidities. So where there is a sliver of truth, there is some published data that doctors are doing on vibration. We call it in the medical world, we call it vibration therapy. External vibration only. These women did not put anything in their vagina. And their pain got better, their sexual health got better. So we are really kind of we're going to medicalize sex, right? Of like, it actually, you can say, we've got science on our side now. These are useful tools. They're not in the back corner in a shady part of town in the store you have to go to. There's great high quality products that really do make a difference.
The only problem is you go late to work a lot of days in the morning. And so,
And so, I mean, how do we start having these conversations with a partner, either with a long-term partner or with a new partner? Can you share?
Yeah. So I had the weirdest dream last night that I showed up with 2 big duffel bags of vibrators for you all, and we passed them all out. And then I was like, oh God, I didn't ask Donna Klassen if we could do this. And I got all upset. So, but next Menoposium, we'll have them, because I think show and tell is great, even if you don't use it generally. And one thing I do when I try to help my patients begin to get their head around using a sex toy, if they never have, is first of all, I tell them, use it on G-rated parts of your body. For real. Nobody wrote a book that said you have to shove something in your vagina or even put it on the vulva, as good as that feels. So you can start with your arms, your legs. You can progress, if it feels good, because it does, to the sides of your breast or to your inner thighs. I always tell people, start G-rated, and then you can go PG, and then you can work your way up to R and X. So if you feel intimidated or you've never bought one, try one that doesn't look like a penis and try it on a G-rated part of your body and kind of go from there. As far as talking, that's a much longer conversation, but I'll try to get it really quick. The when, where, and how really matters how you talk about sex. When, I want you to be in parasympathetic mode. That means relaxed, but energized, excited to do this. I want you to be not defensive or reactive. I want you to be not accusatory either. My mnemonic is halt. If you're hungry, if you're angry, if you're lonely, or if you're tired, do not talk to your partner about sex. It will not go right. So halt, hungry especially. Where? I find on a walk or in a car is great. Why? You're facing forward. You don't have to look at anybody's eye rolls or your own facial expressions that are giving away what you don't really want to give away. So straightforward, think about a therapist's couch. It's easier to speak when we're not looking at the therapist. Same thing, just try that. And the how. The how is probably the most important. You want to open with a compliment or a memory. Gosh, remember when we were in St. Lucia? You know what I really loved? I loved blah, 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 blah. You want to add feedback, but in a positive way. And then you want to close with a compliment. So these are all just kind of very general therapy tools for how to speak to someone when you have something awkward to say. If you're not sure, practice. I'm not kidding. Practice with a girlfriend or in front of a mirror. But you have to open that sexual conversation. We talk about everything with our partners, from failing calculus grades to taxes to how much your mother-in-law pisses me off or my mother-in-law pisses you off, but we don't talk about sex. So I encourage my patients to have a yearly or monthly or quarterly sexual check-in for real. The first one's the hardest, but I'm happy to help you figure out how to do it.
And communication, I think I've heard Dr. Casperson, communication is lubrication.
Yeah.
We've reached our final time. I'd like to close off, Dr. Casperson, having you share, how can we take everything that we've spoken about today into the doctor's office?
So yeah, so just to repeat the question, how do you do this in real life, right? So what I recommend is know your stuff. I mean, I joke that I work really, really hard to make my clinic super, super easy, because all the women that come see me, they've read my book, they've done my podcast. They're like, give me the things, right? Like, the more educated you are going in, the more you can get to the nitty gritty of like, what dose, what type, what blah, 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 what pharmacy should I send this to, right? Like the nitty gritty stuff. So it's like, know your stuff, know what you want, know what's out there as far as guidelines. We have GSM guidelines now. We have an international consensus on testosterone for low libido in women. International consensus. The world doesn't agree on much. We have that. They're both free online. You can bring those into your doctor, and you can, and you have to be specific about what's bothering you. You have to tell them how much it's, I joke with hot flashes. I'm having trouble sleeping. Very different than I have 18 pairs of pajamas because I have to change them 4 times a night because I'm soaking wet. Like, be specific about it. Be like, listen, my libido, my pain with sex and my libido is so concerning to me because I love my partner, or my relationship's on the rock. Like, this is a real healthcare problem that must be addressed. Own it like it is one. And then always promise to follow up. Let's try this for 3 months. I will come back and see how you do. Doctors are spaghetti in your arms when you say that thing. They love knowing how people do. And if you did good, they're going to take that and help the next woman. So follow up, follow up.
Wow. Thank you so much. We've covered so much today, from the biology to treatments to the psycho-emotional aspects of sexual wellness and menopause. Now we'd love to hear from you. We only have time for 3 questions.
2 questions. And please try to keep them, try to keep them to a sentence or 2. But would love to take one from the room. Okay. And a reminder that we will be hosting a follow-up to answer more questions on May 20th. So keep an eye out for that RSVP.
Ask your thoughts on Osfina.
Yes, Osfina. It's the stepchild that always gets forgotten. So Osfina is in the new GSM guidelines. Ospemifene, Osfema, that's brand name and generic. It is an oral SERM, selective estrogen receptor modulator. Great for bones, slightly higher risk of hot flashes, but is FDA approved for GSM. Think of the people, either I have rheumatoid arthritis, I can't see where my vagina is, I'm too big to put something. There are many people that can't put something in their pelvis, a nursing home population, right? So this is the only oral medication that, the way it works in vaginal tissues, it helps treat GSM. It's safe, it's been around for a while. Money is an issue with it, it's expensive. But it's in the new guidelines. Great oral option for people who just can't do, for whatever reason, a pelvic local therapy.
Thank you.
Great. Final question.
Hi, if you're on an estradiol patch, should you also be doing the vaginal estradiol cream?
There's no, yeah. Oh, I was going to say there's no shoulds in menopause. It's not one size fits all. The data is about 20 to 30% of women who are on systemic hormones do also have vaginal. New GSM guidelines, print them out, take them to your doctor. It says in there, women on systemic hormone therapy can be on vaginal estrogen. It's in print, it's free online. Here, a quick math problem. Estrogen, systemic estrogen raises your estrogen to level X. Whatever that is. Vaginal estrogen raises your systemic estrogen to 0. What's X plus 0? X. There's no reason you can't be on both. But that's an individualized question. This is the last stop on the train, right? The patch is like brain, bone, heart, all the things is last stop on the train. It usually does need a little more because it works so well. And again, like Dr. Millen said, we're replacing some of your hormones we're not making you 24 again.
Thank you so much. I hope you're leaving today with some answers, but also with a renewed understanding that your sexual health isn't optional. It's really fundamental to your well-being, your vitality, and your longevity. Thank you so much to our panelists, Dr. Casperson, Dr. Shepherd, Dr. Sophocles. Thank you for sharing your work, and thank you for doing what you do every day to elevate women's healthcare.